Welcome to this in-depth medical tutorial on peptic ulcer disease, also known as PUD. This tutorial is intended for medical professionals, students, and anyone with a strong interest in healthcare. By the end, you'll gain a clear, structured, and clinically grounded understanding of this important disease. Let's begin. By definition, peptic ulcer disease, or PUD, is a condition in which ulcers form on the lining of the stomach or the first part of the small intestine, most commonly, the proximal duodenum. These ulcers typically measure at least 5 millimeters in diameter and penetrate into the submucosal layer. At its core, peptic ulcer disease, or PUD, reflects a breakdown in the delicate balance between aggressive or damaging factors, such as gastric acid and pepsin, and the body's protective mechanisms. These protective mechanisms include the secretion of mucus and bicarbonate, the presence of prostaglandins, and adequate mucosal blood flow. Pathophysiology. The gastrointestinal mucosa is normally protected by a finely balanced system of defense mechanisms. Like we mentioned earlier, these include mucus and bicarbonate, which protect the stomach lining, prostaglandin, which enhances blood perfusion, and an adequate blood supply. These help in preserving the integrity of the stomach lining against constant exposure to harsh gastric secretions. This delicate balance is lost when the damaging factors become excessive, thereby overpowering the protective defenses of the gastrointestinal mucosa, consequently leading to its erosion and ulceration. The primary damaging factors in peptic ulcer disease include infection with Helicobacter pylori organism, a gram-negative, spiral-shaped bacterium that colonizes the gastric mucosal layer. It produces urese, which generates ammonia damaging the protective lining. It causes chronic inflammation, increases gastrin release, and stimulates excessive gastric acid secretion. Another major cause is the prolonged use of nonsteroidal anti-inflammatory drugs, or NSAIDs. These medications inhibit cyclooxygenase 1, or COX1, leading to reduced prostaglandin synthesis. As a result, there's a decrease in mucus and bicarbonate secretion, a reduction in mucosal blood flow, and impaired healing. All these and many more, which we shall discuss next, culminates to make the lining susceptible to injury by acid and pepsin. Etiology and risk factors. Now let's explore the causes and risk factors of peptic ulcer disease. The two most common causes worldwide are Helicobacter pylori infection and chronic use of NSAIDs, including aspirin. These two have been discussed already. Other important risk factors include a family history of peptic ulcer disease, increasing age, smoking, alcohol use. Physiological stress, as seen in critically ill patients with major illness or trauma, can lead to mucosal ischemia and impaired blood flow. This compromises the integrity of the gastric lining, promoting ulcer development. The resulting condition is known as stress-induced mucosal injury. There are also rare conditions, such as Zollinger-Ellison syndrome, which is caused by a gastrin-secreting tumor known as a gastrinoma. This condition leads to excessive gastric acid production, which can overwhelm the mucosal defenses and result in severe ulceration. Gastrinomas can be located in the pancreas, duodenum, or stomach. Regardless of the cause, the end result is the same. Acid and pepsin penetrate the weakened mucosa, relentlessly digesting the tissue and forming ulcers. It's important to emphasize that while spicy or acidic foods do not cause peptic ulcers, they can irritate the stomach lining and may worsen symptoms in individuals who already have an ulcer. Some of them include fried or greasy food, pepper, carbonated, orange or lemon, chocolate, and many others. Types of peptic ulcers. Types of peptic ulcers based on location. We have gastric ulcer and duodenal ulcer. Gastric ulcers most commonly occur along the lesser curvature, and pain is usually worse shortly after eating. Duodenal ulcers develop in the first part of the duodenum, just below the pylorus. Pain usually begins 2 to 3 hours after eating and may even awaken patients at night. Eating often provides temporary relief. Other notable subtypes include stress-induced ulcers such as Curling's ulcer, following burn injury, and Cushing's ulcer, associated with critical conditions like increased intracranial pressure, sepsis, ICU admission, iatrogenic ulcers which develop during hospitalization or medical procedures, refractory ulcers which fail to heal despite adequate treatment, idiopathic ulcers with no identifiable cause, Zollinger-Ellison ulcers caused by gastrin-secreting tumors called gastrinomas, and Meckel's diverticulum ulcers found in a congenital pouch containing ectopic gastric mucosa. Clinical manifestations. The hallmark symptom of peptic ulcer disease is epigastric pain. This pain is often described as burning, gnawing, or churning, located in the epigastric region, though it may be perceived in the chest behind the breastbone. It can radiate to the back, shoulder, neck, or around the umbilicus. May be associated with shortness of breath. The pain can be triggered or worsened by hunger, food depending on the type, especially certain kinds of food like spicy and acidic foods, NSAID use, smoking, or emotional stress. It may be temporarily relieved by leaning forward, standing upright, certain food, rest, drugs like proton pump inhibitors and antacids. Other common symptoms include bloating, frequent belching, nausea and vomiting, and early satiety. Alarm signs that suggest complications and warrant urgent medical attention include persistent vomiting, passage of black tarry stool called melena, vomiting blood known as hematemesis, difficulty swallowing, dysphagia, severe abdominal pain possibly indicating perforation, and signs suggestive of malignancy such as unintentional weight loss or persistent indigestion. How do we make diagnosis of PUD? Diagnosis of peptic ulcer disease starts with a detailed clinical history and physical examination, guided by characteristic symptoms such as epigastric pain and other symptoms. Once suspicion is raised, confirmation requires targeted investigations. Evaluation begins with testing for Helicobacter pylori, the leading cause of peptic ulcers. The urea breath test is the gold standard, non-invasive, highly accurate, and suitable for both diagnosis and post-treatment confirmation. Stool antigen testing is also reliable, cost-effective, and widely used. Serologic antibody tests, although accessible, are less accurate for detecting active infection. They may remain positive long after H. pylori has been eradicated and are not recommended for confirming cure. For patients over 50, or for those presenting with alarm symptoms, including gastrointestinal bleeding, persistent vomiting, dysphagia, unexplained weight loss, or iron deficiency anemia, upper gastrointestinal endoscopy is essential. Endoscopy allows direct visualization of the mucosa, identification of ulcers, and biopsy to detect H. pylori and rule out malignancy. Several tests can be performed during endoscopy. The rapid urese test, which offers quick detection of H. pylori. Histological examination provides detailed analysis of mucosal changes. Bacterial culture and polymerase chain reaction, or PCR, may be used when resistance is suspected or when initial results are inconclusive. In low-resource settings, rapid diagnostic tests using blood or stool may offer a practical alternative, though their diagnostic accuracy is limited and they should not be used to confirm eradication. Supportive investigations further assess complications. A complete blood count can reveal anemia. Fecal occult blood testing may detect hidden gastrointestinal bleeding. If perforation is suspected, abdominal imaging, such as an upright X-ray or CT scan, may show free air or other signs of acute pathology. In settings where endoscopy is not readily available, an upper gastrointestinal series with contrast can be considered. Though less sensitive, it remains a useful tool in selected cases. Peptic ulcer disease can lead to serious and sometimes life-threatening complications. The most common is upper gastrointestinal bleeding, which may present as hematemesis, vomiting of blood, or melena, black tarry stools caused by digested blood. Another major complication is perforation, where the ulcer creates a hole through the wall of the stomach or duodenum. This results in sudden severe abdominal pain and can lead to peritonitis, often requiring emergency surgical intervention. Pyloric stenosis, also called gastric outlet obstruction, can occur due to chronic inflammation, scarring, and fibrosis that narrow the pyloric channel, leading to vomiting, bloating, and early satiety. In rare cases, chronic gastric ulcers, especially those left untreated, may undergo malignant transformation, developing into gastric cancer. Treatment overview. Treatment aims to eradicate H. pylori infection if present, promote ulcer healing, prevent recurrence, and manage complications. For bleeding ulcers, initial steps focus on hemodynamic stabilization with intravenous fluids and blood transfusion if needed. Endoscopy should be performed within 24 hours. If active bleeding is identified, endoscopic therapy using clips, thermal coagulation, or combined injection method is applied. High-risk patients receive high-dose intravenous proton pump inhibitors, or PPIs, an 80 mg bolus, followed by an 8 mg per hour infusion, or intermittent dosing of 40 mg 2 times daily. After stabilization, patients transition to oral PPI therapy, typically 40 mg daily, or 20 mg twice daily, for at least 2 weeks, with the duration tailored to the underlying cause, findings, and clinical response. If bleeding recurs despite endoscopic control, angiographic embolization or surgery may be necessary. H. pylori-associated ulcers. If H. pylori is detected, eradication therapy is initiated. This continues the PPI already in use and adds 2 antibiotics. In areas with low clarithromycin resistance, first-line therapy is a 14-day triple regimen: a PPI, clarithromycin, and amoxicillin or metronidazole if the patient is allergic to penicillin. In regions with high clarithromycin resistance, or after triple therapy failure, bismuth quadruple therapy is preferred. This includes a PPI, bismuth, tetracycline, and metronidazole. Salvage options include levofloxacin or rifabutin-based regimens. A levofloxacin-based regimen typically consists of levofloxacin combined with another antibiotic such as amoxicillin or metronidazole, along with a proton pump inhibitor, PPI, like omeprazole. Rifabutin-based therapy includes rifabutin and amoxicillin, also combined with a PPI. Previously failed regimens should not be repeated. Confirm eradication with a urea breath test or stool antigen test at least 4 weeks after therapy, withholding PPIs for 2 weeks beforehand. NSAID-induced ulcers. Discontinue NSAIDs when possible. If NSAID use must continue, switch to COX-2 selective inhibitors and co-prescribe a proton pump inhibitor for mucosal protection. Stress-related ulcers. Critically ill patients, especially those on mechanical ventilation or with coagulopathy, should receive PPIs or H2 receptor blockers for stress ulcer prophylaxis. Idiopathic and refractory ulcers. Ulcers without identifiable cause or those resistant to treatment warrant high-dose PPI therapy. Consider rare causes such as hypersecretory states or malignancy. Some patients may require long-term maintenance treatment. Other agents that support peptic ulcer healing include mucosal protectives like sucralfate and bismuth, which form a barrier over the ulcer base. Bismuth was mentioned earlier in quadruple therapy. Misoprostol, a prostaglandin analog, enhances mucosal defense. And in some settings, cytoprotective agents like ribamapide or zinc carnosine are also used to promote healing. Surgical management. Surgery is uncommon, but may be necessary for complications such as perforation or obstruction. Perforations are treated with laparoscopic omental patch repair, known as Graham's patch. In cases of refractory or recurrent bleeding ulcers, a vagotomy may be indicated. This procedure involves cutting part of the vagus nerve to reduce acid secretion. Vagotomy can be done with or without gastrectomy, depending on the clinical situation. For gastric outlet obstruction, surgery may involve a pyloroplasty, where the narrowed pyloric channel is surgically widened to enhance gastric emptying. In more severe cases, a gastrojejunostomy may be performed, creating a new connection between the stomach and the jejunum to bypass the obstruction, followed by either a Billroth eye reconstruction, where the stomach is joined to the duodenum, or a Billroth II, where it is connected to the jejunum. Post-surgical complications include dumping syndrome, delayed gastric emptying, nutrient deficiencies such as iron, B12, and calcium, diarrhea, weight loss, and anastomotic leaks or strictures. Lifestyle and long-term management. Advise patients to discontinue NSAIDs or switch to COX-2 inhibitors, quit smoking completely, avoid or limit alcohol, especially during treatment, increase intake of food rich in fiber such as oatmeal, brown beans, pawpaw, mango, avocado, watermelon, banana, corn, carrot, and pumpkin, and probiotics like yogurt. Eat smaller, frequent meals, manage psychological stress, maintain hygiene to prevent H. pylori reinfection, avoid lying down immediately after meals and elevate the head during sleep, adhere strictly to medication regimens, and attend regular follow-ups. Follow-up. Confirm H. pylori eradication after treatment and monitor for recurrence. Patients on long-term PPI therapy should be regularly assessed for side effects such as nutrient malabsorption or bone demineralization. Educate patients on alarm symptoms, recurrence risks, and the importance of adherence to treatment and lifestyle recommendations. Closing. Peptic ulcer disease is a manageable condition with established protocols for diagnosis and treatment. With timely intervention, effective therapy, and preventive care, most patients achieve full recovery. I hope you enjoyed this video. Stay updated by subscribing to the channel. Thank you for listening.